Hello, my name's Tom Hellyer. I'm a clinical academic at Newcastle University, and I'm a consultant in intensive care medicine. I'm also the board chair for this program, the Infections in Critical Care Quality Improvement Program, or ICQIP, and that's the program I want to speak to you about today. I've badged this as UKHSA. I don't work for UKHSA, but they're a big part of this program. So this is a huge hall with people scattered everywhere, but I'd be quite keen to know if what people's knowledge of ICQIP is. Can you raise your hand if you've heard of ICQIP? Okay, so I'm speaking to the right audience because there's a lot of you who haven't heard of it, and you'll hopefully learn about it today. So ICQIP is a surveillance program that is predominantly focused around central line bloodstream infections. So I guess the kind of obvious thing to say is that central lines are incredibly common. So even if an infection is an infrequent event in a highly used device becomes a big problem. And there's approximately 1.3 central line bloodstream infections per 1,000 ICU central line days. And when these infections occur, that carries a real risk and a real harm to patients. So patients who get a central line bloodstream infection have almost a threefold higher chance of dying as a consequence of that infection. But there's also higher lengths of stay in hospital and in ICU, and a higher costs associated with it as well. I'm going to make a small point on definitions because it becomes relevant later in the talk. But when we talk about central line associated bloodstream infections, we broadly split them into two. So catheter-associated bloodstream infections is essentially a laboratory diagnosis. So did you have a blood culture that was a potential pathogen, and did you have a central line at the time? Versus catheter-related bloodstream infections, which is a clinical diagnosis. So you need to have much more data around signs and symptoms of infection. So that's quite relevant for later on. To talk about this program, we need a bit of a history lesson. Many of you will be familiar with the Michigan Keystone Project from 2006. It was a hugely influential piece of work carried out by a guy called Peter Pronovost. And it was a quality improvement program that aimed to reduce the rates of central line associated bloodstream infections. And I guess at the core of it, there was this bundle of care that focused on 5 evidence-based interventions to reduce bloodstream infections. So these included hand washing, full barrier precautions, cleaning the site with chlorhexidine, avoiding the femoral line where possible, and removing unnecessary central lines, which, you know, looking back now, may all seem quite obvious in our practice, but of course these were important changes at the time. It was more than just those 5 interventions. It was a whole package of how this program was implemented and delivered within this program. And the program included 103 ICUs in the Michigan area in the USA. And so in that study, they managed to reduce their catheter-related bloodstream infections from 2.7 per 1,000 catheter days down to 0, and within the 18-month period of the study. And then there was a follow-up study that showed that it was maintained up to 3 years. That was hugely impactful, and a really big shift in how care was delivered with this particular focus around safety. And so at the time, there was an initiative that was driven by the Department of Health called the Match in Michigan project, and some of you in the room may have been familiar with this. So essentially the idea was to replicate the Michigan Keystone project in the UK. So there was a few bits to this. The first was actually developing a system for reporting infections in critical care. The technical interventions are very similar to the Keystone project around having the CVC insertion checklist, having a CVC trolley with an inventory on it, and so on. And also, those 5 interventions, they were also captured by the Department of Health high-impact interventions. So they formed part of the technical interventions. And then there was the non-technical interventions, and this was around the culture that was developed and around communication and training. And in the Match in Michigan project, central line infections reduced in the UK from 4.4 infections per 1,000 central line days down to 1.7. And with all of these studies, the dotted line is CVC utilization, which is about 60-65%. And the main thing to say there is that that is stable, and so the drop in infections doesn't represent a fall in CVC usage. It's quite interesting to think about the differences between the Keystone project and Match in Michigan. And if anyone's interested in this kind of work, from where you're sitting, you may not be able to see the reference. The researcher is Mary Dixon Wood, who did some fantastic work on the implementation of both of these projects. And it's a really interesting read and really interesting to draw comparisons. So in Match in Michigan, it was a huge success because there were these multiple social and cultural elements to it. So there was a pressure for ICUs to conform and to buy into the project. There was a densely networked community that allowed people to communicate, share best practice. They adopted the characteristics of a social movement, so it became this mission to solve this social problem of CVC infections. There was multiple interventions that shaped this cultural commitment, and there was even an element of having soft and hard tactics around soft tactics to encourage people to take part through persuasion, and infrequently some harder tactics to sanction sites if they didn't do so well. So it's really quite interesting to see the cultural elements around the Michigan Keystone. In contrast, Match in Michigan actually, beyond those headline numbers around how CVC infections dropped through the intervention, actually at a kind of granular site level, there was a really mixed picture around how the program was taken up. So there was one site that was absolutely transformed, really bought into it, huge difference to their practice. There were some sites that were already kind of working in the space and they boosted and got a bit better. And there were some sites where there was very little impact from the program at all. And some of the factors that influenced this, one was that, so the intervention was the same, so the components of the bundles was the same, but the implementation of it was quite different. It wasn't quite as immersive as the Keystone project. It was also viewed by, particularly in the low impact sites, as very much a kind of top-down initiative. And so there's a real problem with the fact that this was viewed as being government-owned and not profession-owned. And there's really variable local leadership. So really quite interesting to compare, and I know that sounds a little bit negative around the Match in Michigan bit, but it's quite interesting to know that background because it's relevant to some of the challenges that ICQUIP faces at the moment, and I'll come on to those. So what is ICQUIP? It's a surveillance program, primarily, but as the name suggests, there's quality improvement, and it's quality improvement primarily driven through the act of surveillance. It is a surveillance program of bloodstream infections caused by any organism. It's conducted in critical care units and with a scope that includes adult, pediatric and neonate. And since it's UKHSA, this is an England-only surveillance program, but through the UKHSA works very closely with devolved nations. So it's actually an organisation that is an amalgamation of a number of professional bodies. So from the intensive care side, there is professional bodies representing the intensive care medicine, intensive care society, British Association of Critical Care Nurses. There's representatives from the infection and microbiology community, infection prevention and control community. From the epidemiology, this is where UKHSA slot in. So UKHSA, although they provide most of the technical support, it's not owned by them. They are a kind of equal partner in the programme. And we have representation from NHS England as well. And we also work very closely with national audit programs. So in particular, I'll mention these in case you're not familiar with them, but ICNARC is the adult intensive care audit program. So Intensive Care National Audit and Research Centre. NNAP is the neonatal audit program, and PCANET is the Pediatric Intensive Care Audit Program. So, as I mentioned, ICQIP was born out of the Matching Michigan study. That's going back to 2009, and it was initially formed in 2011. And sorry, I haven't put a box around this one, but if you look at 2016, that's when it was rolled out. Importantly, it's actually involvement in the ICQIP program is part of the NHS specification for adult ICUs. We were also part of the dashboard for CQC, but that system has now changed now, so that's slightly less relevant. So here is what the surveillance that we're performing. So each year, ICQIP reports gives an annual report on bloodstream infections. And in the last report, actually, it shows data going all the way back to 2016. And the main thing to highlight, the bloodstream infection rates have been, were largely static at the start of the program. And then there's this big spike, which corresponds with COVID-19. And then after COVID, the CVC infection rates start to come back down to where they were pre-COVID. So this is fairly consistent with what was shown in other countries such as the US as well. And these are the data that we monitor through the surveillance board. So this is the rates of ICU bloodstream infections per 1,000 ICU patients. So this is bloodstream infections, not CVC infections. And you can see, I don't know if this laser's working, but if you look at the bottom row of that table, it's fairly consistent around 4 bloodstream infections per 1,000 ICU patient days. And then in these plots, each dot obviously represents a single ICU. And then we also monitor the central line rate, the central line associated bloodstream infections. And again, if you look at the bottom row of that table, fairly consistent pattern of around 2 central line associated bloodstream infections per 1,000 CVC days. The other thing that we monitor are the pathogens, and we're really, you can see this is largely, there's lots of squiggly lines, but there's a kind of variation around an average, and but it allows us to be able to track if there's any particular spikes for particular outbreak or particular concerning pathogen that's becoming more prominent in the program. So ICQIP's faced a number of challenges. the headline thing to say is that the program's been running for 9 years, and it is a voluntary program. So I mentioned that it's part of the NHS adult ICU specification, but it is actually a voluntary program. And only 49% of adult ICUs take part in the program. And the rates of participation from pediatrics and neonates is really low. And for the pediatric and the neonates, it is particularly because of the pre-existing audit programs, PCANET and NNAP, and there's overlap, which really prevents buy-in from that community. But we ran a survey of users of ICQUIP to work out what was working and what wasn't working. And the overlap in national audits was clearly a big barrier, but also there was a burden of data collection, and particularly around, and I mentioned at the start, this distinction between the catheter-associated bloodstream infections and the catheter-related bloodstream infections. So up to this point, the program has been collecting data for all of those things, which makes a pretty big burden of data collection. And of course, you guys work in the NHS, and it's quite hard to ask people to put data, particularly if they can't see a clear benefit. So burden of data collection was a really big point. There's a problem around awareness of ICQUIP. A lot of people hadn't heard about it. A lot of people in this room hadn't heard about it. So it's really important that we raise awareness. There's a clear message from the clinical community that they want more. The program it was born out of Match in Michigan, so clearly very closely aligned with central line infections, but the program was never just about central line infections, and there's a clear message from the community that they want other infection surveillance as well. And a big question around clinical utility. So how do we use these data, and how can it inform practice at our sites? And when you consider this balance of the burden of data collection against the clinical utility in our very strained NHS system, lots of questions are raised by sites around resource allocation, and is this the right place to allocate resources? Just as a little hobby project, when the Match in Michigan program was happened, there was a lot of interest in prevention of central line infections, and it feels like it's possibly dropped off the agenda a little bit. So I don't know if people use AI much, but I thought this would be a good question for AI. So I used Anthropic, and I asked it to plot me a graph of publications related to central line infections and CVC infection surveillance, which it did, and it plotted me this interesting bar chart, which shows this huge increase in publications up to the Match in Michigan project in 2013, and then the bars kind of level off. So then I asked it to put another line and adjust it for the number of publications on PubMed. So the red line is adjusted per million publications on PubMed, and you can see that there is a peak around the time of Match in Michigan, and then it drops off. So, I mean, notwithstanding that it's AI and it's a little bit of a black box, but you know, it does feel like there's been a shift in the agenda. As an ICQUIP board, we've done a huge amount of work in the last year to really try and get the program on a new track and really address the needs of the clinical community, and to try and make a much kind of richer offering that is going to encourage people to engage in the program and take part. So in the short term, we have retired the catheter-related bloodstream infection definition, so that will have an immediate effect on burden of data collection. We have, so adult ICUs, most ICUs submit data to ICNARC, the National Audit Programme, and there's a number of platforms that is done on. The most common is a platform called Medicus, and we have now a module that's embedded in Medicus so that when you go to enter your data, it's kind of all in one system now. So that eases the process of data collection. We're doing a lot of work with PCANET and NNAP to allow data sharing so that, again, we don't duplicate the work that people are doing. So if pediatric and neonatal ICUs are submitting to their national audits, that actually we can use those data as well to inform our surveillance program. And we've done a lot of work with engaging with the clinical community to ask about really what they want from the program and how we're going to change it. And so that kind of leads into the kind of medium term where we're already responding to the feedback from the clinical community. So for the adult ICUs, again, similarly to trying to share data between the pediatric national audit programs, we're doing a piece of work with ICNARC to look at whether essentially we can collect the same data through their program and essentially have some kind of data sharing agreement that would ease the burden of data collection. There was a very strong message from the clinical community that people are really interested in monitoring their ventilator-associated pneumonia rates. Now, that is a hugely challenging and in many ways contentious area around definitions of VAP, but that is a piece of work that we have already started to do, the kind of field epidemiology work to work up the definitions that will hopefully move us to a position where we will add VAP into the program. We've got the ability through UKHSA to link the ICWIP data with laboratory data and also with potentially with antimicrobial uses data. So there's a real focus on how we make the reports and the offering of ICWIP much more useful to ICUs. We have quality improvement is in the title, but I must, quality improvement is very much through the act of surveillance. It's down to sites to really drive their own QI. But one of the things that we're doing is we're going to be looking to create a community and a space where we can present best practice and some ideas for how QI can be delivered at sites so that people can really work on getting the clinical utility from the program. So in the longer term, as I mentioned, we're planning on having additional infections in the program. It'd be really great that we can start to use this as a platform for much wider standalone projects that are value to the clinical community, and really we're looking to get much wider participation in the program. So to summarize, many of you in the room have not heard of this, and participation is pretty low, but I must stress that this is the English ICU surveillance program. So it's really important that us in ICWIP make the offering better, but actually you guys as a clinical community kind of engage with it, and if you're not taking part in it, please do consider taking part in it. We're doing a lot of work to improve the program and how we engage with the community, and we do plan to expand the surveillance. And a lot of units will monitor their own infection rates, but if they don't take part in the program, they're only monitoring their own infection rate, and it's a really big miss if you're unable to benchmark against national averages. So that's the really key offering, is around benchmarking and to drive improvement. And I think it's really important that we try and get ICU surveillance back onto the agenda in the UK. So thanks very much.